So hi, my name is Dr. Hafifa Siddiq. I'm an assistant professor at the Charles R. Drew University of Medicine and Science. I am a registered nurse and a researcher with a background in acute inpatient psychiatry and community-based mental health services. So my research interests lie in the mental health disparities of immigrant and settled refugees here in the U.S. So today I'll be talking about a community-based collaborative action research project in partnership with a refugee-serving organization, Access California Services. And we're based here out in Orange County, California. So for this talk, I'll be briefly discussing the refugee crisis and the mental health disparities of displaced populations, as well as the current mental health services system. And then I'll be presenting some findings from our systematic review of the literature looking at community-based mental health services for this population. And then I will be reviewing some of the findings of our key informant interviews with multi-sector community leaders providing services for resettled refugees here in Southern California. And finally, I'll just be summarizing some of the findings of our community needs assessment with over 124 older adults who are immigrants and refugees, and their prioritized social and psychosocial needs. First off, we have a crisis of war and displaced people across the globe, and that has become unprecedented every year since almost since World War II. And refugees are displaced populations unable to return to their home countries due to a well-founded fear of persecution. Refugees from Muslim majority countries like Afghanistan, Iraq, Syria represent over half of the world's refugee population and are underrepresented in public health research. Displaced populations experience trauma and stressors from the different phases of their migration journey, from pre-migration phase to in transit to the post-migration setting. And these experiences and stressors have led to the increased prevalence of mental health issues, including depression, anxiety, post-traumatic stress disorder, as well as psychological distress. And we know how detrimental the consequences are of unaddressed depression and anxiety and are to morbidity and mortality, especially for older adults now aging in the US or who have arrived at older ages. So therefore, it's imperative to prioritize the mental health needs of this population. To address mental health across populations in general, the World Health Organization recommends a mix of services that should focus on more preventative, more self-management, as well as informal community mental health care, mental health services that are integrated within the primary care setting, as well as community-based mental health services. And these service settings represent a setting where the needs are much higher and the costs are a lot lower than addressing mental health issues in a more acute state with specialists in tertiary or acute care settings. And unfortunately, we do spend a lot of money investing at the tertiary level than what we do spending at the community level. And currently, there's really no national framework for addressing the mental health of resettled refugees here in the US. What we do have at the current time is a really intensive vetting process that sometimes take years, which include a required pre-arrival medical screening and one required domestic medical screening once they arrive here in the US, and which prioritize screening for more communicable diseases over chronic or mental health issues. So a national organized system is really almost non-existent, but even at the local level, the systems may be lacking depending on what resources are available in the community. So to get a better sense of the state of the science in terms of community-based mental health services for resettled refugees, I turned to the literature, peer-reviewed literature, that focus on services provided for refugees from the Middle East, Africa, and other Muslim majority countries, including Afghanistan. What we found was very limited studies. A total of 11 were published between 1990 and 2020, and the majority of the studies focused on, or were primarily qualitative pilot studies with programs that focused on early screening. And our findings overall, we identified programs that incorporated social-based activities to like exercise, sewing circles, and these programs sometimes delivered education about mental health. And most of these studies focused on those who are recently arrived and little focus on older adults. While these programs were community-based, the extent to which community members from the refugee community were involved in the research process were really underreported in the publications. And it wasn't really explicitly shared, right? So in community-based participatory research process, we really want to involve our members of the community from the beginning of the research project, involving them in the research question development, data collection, data analysis, and dissemination phase. Additionally, despite Muslims making up about half of refugees here in the U.S., collaborations with mosques and other Muslim organizations were also limited. And finally, I found that there is a need for high-quality randomized controlled trials. So the goals of academia in producing new knowledge and innovative solutions to challenges that under-resourced communities face, as well as the equity-driven goals of community-based organizations, can come together through this process of community-based participatory research. So in partnership with Access Cal, we developed interview questions to ask and examine perspectives of multi-sector community key informants and community leaders across Southern California, mainly focusing on LA area and Orange County. And we interviewed faith leaders, case managers, social workers, counselors, as well as healthcare providers. And using thematic analysis, I was able to uncover 3 major themes around the keenness of social isolation and the vulnerability of older adult refugees, and how mental health care programs can be culturally tailored to refugees from these regions, and finally and the overall fragmented pathways to culturally appropriate community-based mental health services, if they were available. For example, we know that it's well established that loneliness and a lack of social connectedness are associated with a range of physical and mental health problems. And more specifically, social isolation is a key risk factor for Alzheimer's disease and related dementias, and making this a critical risk factor to address in future interventions. A lot of the participants emphasized this need to broaden our definition for mental health, especially when it comes to this population, and to have a more broader psychosocial approach to addressing the mental health needs of older adults especially. Some program coordinators even talked about preference for social-based therapies for older adults, like gardening and social activities, and this will, doing so helps combat the stigma around accessing mental health services through a therapist or a counselor one-on-one. They emphasize the importance of language and gender concordance between the service provider as well as the refugee client. And these findings around the different barriers to mental health services have been identified in prior literature in other refugee communities. So in terms of barriers like language, difficulty with the English language, and not having transportation to services can be major barriers for older adults. So we also found that there were very fragmented pathways to community-based mental health services, and specifically more culturally tailored mental health services where, counselors or therapists either speak the same language or share the same background with their clients. And knowing that mental health is an important need in the community, faith leaders still had difficulty referring to services, and this is due to just stigma and limited knowledge around what mental health and treatment is. And those who are more comfortable addressing mental health as a faith leader received training and had background in social work or counseling, and they still had difficulty following up on referrals that they've made. And this is primarily due to not having capacity or a community navigator who can better close the loop on these referrals out from the community setting. There's also an important point that healthcare providers brought up, which was, those who provide services in more high resettlement regions, it should be good to know what community-based mental health services are available in the community so that they may refer their clients to. From the perspective of social service organizations, counselors and case managers, who had a mental health department within their organization had an easier time, being able to refer in-house to services that their clients need. And the World Health Organization recommends integrated mental health care within the primary care setting, but we should also be emphasizing integrated mental health care within social service settings as well. In addition to the community level perspective on this issue, we conducted a descriptive analysis of community needs assessment survey of the social and psychosocial health needs of older adult immigrants and refugees residing in Orange County. And the service priorities that were rated at either very important or above by older adults included things like accessibility needs, caregiving support, safety, and elder abuse resources, end-of-life resources, as well as digital literacy and English language services. We were also able to identify how social activities that incorporate cultural traditions were rated overall as important or above. These service priorities represent services that older adults, especially in Orange County region, are in need of. So overall, these findings better inform the incorporation of components for a future community-based intervention addressing the overall psychosocial health needs of older adult immigrants and refugees. I envision a program which combines peer and healthcare workers, as well as volunteers, to conduct more extensive case management for older adults that not only provide like service referrals and health assessments, but weekly check-ins from each provider for the purpose of socializing and developing social connectedness with older adults. We believe that such an approach would be successful in addressing both social isolation and potentially decreased depression and psychological distress in this population. In conclusion, envisioning an equitable community-based mental health care system in the U.S. for resettled refugees and other immigrants should incorporate multi-sector partnerships, interdisciplinary collaborations, and programs that are culturally tailored and recognizes the unique needs of older adults and does not forget them. I'd like to acknowledge my community partner, Access California Services, and the staff, as well especially Nahla Kayali, Executive Director, and Nada El Haja, former Refugee Social Services Program Manager, and Ahmed El Haja, Undergraduate Research Assistant. This research was supported by the UCLA Resource Center for Minority Aging Research, Center for Health Improvement for Minority Elderly, and the UCLA Clinical and Translational Science Institute. I'd like to thank my mentors and support from UCLA NCSP, RCMAR CHIME, CTSI, and Charles R. Drew University. Thank you so much.